Welcome to Insight, Health Optimization with Rudy and Sean.
How do you want to die? Well, let's turn it around. How do you not want to die? As Sean said, he had a scare, and I had some friends that had big scares and actually died, and that's how we got to this. We realized that we need to make Russ's talk very, very practical. So we need to know our numbers. Those ApoBs and all the numbers that you saw earlier, if you don't know your own number, it is just on the screen. And then we realized that between us, we've got this passion, but we have to get it out to people, and you have to have real medical knowledge, and this 20 minutes or 25 minutes is not enough. And we realized we feed well off each other. We started a podcast. We've got about 25 episodes now. So if you find something that you think you don't understand, I hope we've touched on most of it in the podcast, or get in contact with us. We've got 2 very good ones lined up. End of this month will be colonoscopies, and the one after will be osteoporosis. But we talk through these things, trying to make it practical. I think, you can find our podcast on Insight. It's on Spotify, on Apple, or on YouTube. And we talk through creatine, supplements, ApoB, and maybe Sean, you can maybe just touch on your little story, and that we just understand where we're going to, because at the end of the day, you don't want to end up on a table that you not know it's coming, because most of these things that, as Russ has said, you can plan. You can plan that I don't want to have dementia, I don't want to have a heart attack, or if I have a heart attack, I want to live as long as I can, have this health span, and say, but I don't want to have a stroke, I don't want to have a heart attack and dementia. That's the main things we can actually plan for. So Sean, maybe just touch on.
Yes, I think, 2016, lying in an ICU, and you look around you and you see obese person, 85-year-old person, and myself. How on earth did I end up getting here? And that triggered the question, okay? Medical doctor, how did I get here? What did I do wrong? That's all the questions going through your mind is, what's going on? And then you start. Then I started on this journey to find out what is actually going on. What is health about? We were at a braai one night, and we realized that many other people have got the same questions. And that's why we're on this journey, to answer those questions.
Yeah, if you think about your car, if you drive your car, you've got a service book in the front. You know exactly when it was serviced. You pretty much have a good idea about how many kilometers are on your odometer. But for your life, do you know? Do you know your ApoB? Do you know your blood pressure? So that is what we want to have, practical knowledge that for yourself, because this is about you. How are you going to know? How are you going to predict? Because that's what Russ is doing. If he has these numbers, you can actually now predict. But this is the things I have to do to not have this red ball hitting you off your life on a Tuesday afternoon, as the Baz Luhrmann song says. It says the real troubles in your life will the stuff that will hit you on an idle Tuesday. So that's what you don't want. You don't want to be surprised.
So the first thing we need to do is we need to remove bias, physician bias. Because the thing that GPs like to tell their patients is, don't worry, it's not too bad. Blood pressure isn't that bad. You're okay. See you next month, type of thing.
Yeah, so we built a model, and we literally, in our inner sight, we literally do not see you before you've had the model. So that we don't say to you, you're going to be okay. The model tells us, if there's a red light on, you say, we have to fix it now. If there's an orange light on, we've got 6 months. If there's a yellow light on, next year. Green, don't worry about it. So that we don't just tell each other, it's going to be okay. Or if there is something that's maybe a little bit off, then we act on it. So you have to have, now that we're talking about AI, you can actually give these numbers to AI, and it'll probably give you a good idea about what should be done. But now you've actually got the practical. Okay, but we are now looking at you, and you get this plan for the next year.
So obviously, early detection saves lives. That's why we're here. Many diseases have silent onset. And Russell, or us, prevention is cheaper than treatment. So that's what we're aiming for. So where do we start? Now, we had a chat about this, and it's difficult because we're going to talk about biomarkers and how do we choose the biomarkers. We do a lot of biomarkers at the clinic, but we need to choose a couple that, that we can present to you today and say, these are the ones that we think you at least need to know. So bear with us, but these are the ones that we've chosen. And from a cardiovascular metabolic perspective, it's the ApoB and lipoprotein little a, the highly sensitive CRP, your blood pressure, fasting insulin, HbA1c, and triglycerides.
So if we just put that into context, why are we asking that? You want to know, so those are the markers, and Russ has had them in most of his slides as well. So they are the markers that will tell you that you are not close to someone that's got metabolic disease. So the one that's there that you probably not have heard about is lipoprotein A. So it's something we never heard before in our medical studies. And as I said to someone earlier today, in medical studies you get taught to spot disease. The problem is if the disease is already there, it's too late. So we like to catch people screening, the start of the screening, somewhere between 30 and 35. We think now, after running this program for quite a while, is probably the best time, because you're pretty much indestructible in your 20s. Like, you are very unlucky if you get something big then, and that's luck. But we see especially the cardiovascular markers change quite a bit around the mid 35. So, but coming back to lipoprotein A, again, Sean's story, he's got a problem that is your genetic risk factor that you can do nothing about at this moment. There is a phase 3 trial going on, but it's like if your ApoB or cholesterol, we'll talk about that a little bit later. We hope we can get to it. But if your ApoB is a problem, it's like a lighter fluid at the bottom that can make this bomb explode. And you don't know if you've got it if you've never been tested. But you only test it once at the moment, because it's yes, a risk, or no. Sorry, Sean, I interjected.
No problem whatsoever. And then we've added some nutritional functional markers as well, which we think is very important to know. Ferritin, vitamin D, VO2 max, and grip strength. And then we will go quickly through them, and then afterwards we can have some questions if there's questions, or when we're allowed to have some questions, question and answer session. But I think for now we're just going to run through them as quickly as we can. I mean, each of these are like an hour plus that you can talk about them. So we're going to just do the quick version. So section 1, we're going to do the cardiovascular and metabolic health section. And what we need to know is that cardiovascular disease is still the leading cause of death globally.
And before Sean goes on, he doesn't look like the guy that should have a stent at 38. And that's what we're trying to say. If you don't know your numbers, it's everyone needs to know these numbers, because, I mean, maybe me, but he's not the typical guy that you think about should be having a heart attack. And that's where he ended, because he didn't know his numbers. And just coming back to this is why we're doing it.
Okay, and in South Africa, 5 heart attacks every hour. That's quite a lot. Cholesterol, ApoB. What does it mean? I mean, how often I get the question, so my cholesterol is 5, is it okay? Well, I don't know. What's your particle number? And I get this blank stare. Particle number, what are you talking about? Say cholesterol. What does cholesterol mean? It means nothing without having a particle number. So, cholesterol is a fatty substance, very important for life. It needs to be transported through the blood system to organs in the body. So how does it do that? So we need to pack it in a vehicle. And that vehicle is a lipoprotein. Okay, the two that you probably heard of, LDL and HDL. That's two types of vehicles transporting this cholesterol through the body. Okay. Now, if we look at that slide, you'll see underneath of each one, 5 millimoles per liter. That's the cholesterol. We measure cholesterol concentration. It doesn't tell us anything about particle numbers. Now, for the same cholesterol, you can have different number of particles. The small particles might find its way into your artery walls, whereas those larger particles might find it more difficult to get there. On that slide, you can see Jerry. They all have the same cholesterol level. Jerry, he's fine, low risk. But Maria, she's got a problem. Okay, same cholesterol level, but different particle numbers. Okay, so my cholesterol of 5, is it normal? Who knows? So we need to answer the question of how many particles do you have? Now, each little LDL molecule has got that little thingy called an ApoB on the molecule. Okay, right, and not just on LDL, but we'll just speak of LDL for now. So if we can measure ApoB, we can know the numbers. The more ApoB, the more little particles you have. Okay, so that's why ApoB is important. You've got a low ApoB number, you've got the big fluffy particles that probably won't cause a problem. But if you've got the small little particles, meaning a high ApoB value, that is a problem. Next to it, you can see the ApoB population percentile. That's taken from the Framingham offspring study. And you can see the numbers there.
So I'm going to interject there again, Sean. So if your GP is doing your cholesterol, like your vitality test, and they say your cholesterol is 6, it doesn't mean anything. But at the end of our medical school, we started breaking serum cholesterol down into HDL, LDL, and triglycerides. So that's the 3 that you probably also have heard about. But the new thinking, lipoprotein A and ApoB, know your numbers. That's the 2 you should know and test. Lipoprotein A once for the moment, but you probably in the next 2 years will be able to treat that as well. But yeah, that is the 2, how you get to this cascade of what we know now.
So now we move to this little one, lipoprotein little a. Well, it's known for many years, but only recently they've actually realized that it's causing a problem. So what is lipoprotein little a? Now, if you look at that picture, you'll see on the right-hand side, there's an LDL molecule, the one that we just spoke of. You can see the ApoB there. But then you see this long tail on the one on the left-hand side. That's little a. That's a problem. That makes that particle more sticky. It causes more clotting. It enters the artery wall easy. Okay. 20 to 30% of the population have that little one. I'm one of those. So the problem with that is that your target for your cholesterol level, if we speak about cholesterol, is much lower. You can't accept cholesterol of 4 is normal. So you need to know the particle number as well as do you have increased risk. So unfortunately at the moment, we have statins in South Africa, mostly. They don't do much about the little a. There's some drugs on the market and there's new ones coming out that might lower it. But we also don't have any studies showing that lowering it will decrease risk. That will come in time. For now, what we do is we manage risk. So we're going to clamp down on hypertension. We're going to clamp down on ApoB. We're going to manage much more aggressive, as if in a person with a lipo little a.
Yeah, and maybe just as we talk about how do you treat these? I mean, there are people hear statins, and we see that a lot. So people say, but I don't want to be on a statin. and that's fine. There is 2 or 3 other ways in South Africa. We also have got bempedoic acid coming soon, and then we've got this new drug, it's not got a name, for lipoprotein A, but you don't need to be on a statin, but you need to treat this if it is a problem. So maybe we should just touch on that. So we've got a lot of people who say, but I don't want to go on any cholesterol medication. Then you say, okay, but then we need to know if this is causing a problem. So if your ApoB is high, then we put you in a scanner. In South Africa, it costs about 3,500 Rand at the moment. Go into the scanner, zoop, zoop, and they quickly check if you're actually making this calcium deposits that's actually going to cause your arteries to narrow. So again, we're not blanketly treating everyone, but should we act on these values? Absolutely. You need to know your numbers to know how close you are to having a heart attack. Just remember that stress test that your GP puts you on, or your cardiologist puts you on, put the electrodes on, and you run or you cycle or you row. You can have an 80% blockage and still pass that test. Okay, so you need to know earlier than that.
And the other thing with that is that 50% or more than 50% of heart attacks happen with the occlusion of less than 50%. So a normal stress test doesn't mean anything.
Okay, we'll try and pop along. There's quite a few things we need to discuss.
Okay.
So just cholesterol, break it down. If your GP doesn't test ApoB and lipoprotein A, get in contact with us or find a new GP. They need to know, okay? Those are values, those are things that is the new way to think about cholesterol.
The other thing is, it's not just about the cholesterol getting into the artery wall, there's also inflammation. So we need to know our inflammation markers. CRP is one of those. And, you need to see everything in context. So if your inflammation is high and you've got a risk, then suddenly your risk is much higher. You need to know your CRP.
C-reactive protein. So you get a normal one and then you get a high sensitivity one. So most people do the CRP to look for inflammation when you're sick, but this high sensitivity CRP very much specific on cardiac risk, and there's much lower values for the high sensitivity CRP. We do that in our tests, and it shows internal inflammation. If we just think what's happening here, so your heart's doing, and then there's a time when it's actually resting. So you've got this internal blood pressure, but when you are injuring that inside of your arteries all the time, we all do, but blood pressure does it more. And then when there's little cells lining the inside of your arteries, and when they get injured, how we fix them is the problem. So ApoB and lipoprotein A, if they get in there to do the fix, that is the wrong fix. You need to have it fixed by the good cholesterol and not by the ApoB and the lipoprotein A. So that's how you form that calcium, just to put the physiology one step further to understand what we're trying to not let happen.
So we've got that 3 markers for cardiac health. This is not a blood test, but obviously, that it's still the silent killer. So you can just have a look there. 1 in 4 men and 1 in 5 women have high blood pressure. Let's have a look at that slide. So I think blood pressure is one of the biggest problems in GP practice. Okay, because most GPs will tell you, oh no, it's not too high. It's okay. When you look at the normal values, and if you go look at the SPRINT trial, it clearly shows that the blood pressure of under 120 systolic versus 140 systolic has got a major impact on outcomes. So we want a low blood pressure. We always institute lifestyle intervention first. And if we're not successful with that, then we'll start on blood pressure treatment. But the lower the better. As long as you don't faint from low blood pressure, the lower the better. It's in the stats, it's in the studies, but for some reason, we all just want people to feel better by telling them, oh, it's not too bad.
And I think just to come back to that, Russ's message, our message here is you are a physiological machine. You need to know these numbers to know what will happen to you. These things have been studied so well over the time. So don't think it won't happen to me. This is very, very well clinically validated. So if you don't know your blood pressure, have it taken. If you're unsure, I mean, there are loads of different machines. We are actually importing something this week that you can actually just wear in the background, and it just talks to your phone and it'll tell you. I mean, there are numerous devices out there that can actually do your blood pressure while you're not even at the GP, if you get what we call the white coat hypertension. But don't let high blood pressure just linger in the background.
Okay, so for cardiovascular health, it's obviously ApoB, lipoprotein little a, CRP, and blood pressure. You need to know those. The next one, diabetes. Okay, so 1 in 300 South Africans develop diabetes each year. It's a staggering number.
Maybe just we must also just say there's two types of diabetes. The diabetes that we're talking about here is probably a bit of a misnomer, but type 2 diabetes is pretty much when you stimulate the system so much with carbohydrates that it actually can't function anymore. As whereas the type 1 diabetics, the guys that inject from young age, is they don't make insulin. So the type 1s don't have insulin. The type 2s have too much insulin, so the body actually gets like insensitive to insulin. So this is what we're talking about, the type 2 diabetic.
Yeah, so the blood test for that, what we test for is the fasting insulin and the HbA1c. I'm going to move quickly to this slide, is that what we need to understand is, and actually needs to walk to, on the right-hand side, you can see that's that little purple channel there, okay? That's a GLUT4 transporter. And on the left-hand side, you see that little fork thingy is the insulin receptor. So how it works is the body is a very interesting machine, but it actually pushes that little tube through the cell wall to get glucose from the blood into the muscle cell. But you need the insulin to bind the receptor before it opens that little tube for the glucose to go in. So initially, we start off in this position where if you measure your fasting insulin, it's still normal. Okay, the system works well. And then we get to a stage where that little transporter tube gets blocked by, and the thinking at the moment is it's free fatty acids in the blood. And then the glucose can't get into the muscle cell, and now we need to get it into the muscle cell. And what the body does then is push out more insulin, tries to push that glucose through that tube into the muscle cell. And now the next step in the process starts is that your fasting insulin starts to go up. Remember, at that point, your blood glucose is still normal. The body ups the insulin to try and push that glucose through. It manages that, but the blood glucose is still normal. So if you get a normal blood glucose test done, it will show that you've got a normal level and that there's no problem going on at the moment.
Yeah, so that's the insulin. You've heard that I'm insulin insensitive or pre-diabetic. This is now where this starts falling in the classification. So you won't be classified as a diabetic. HbA1c will be slightly high, but not over the range, and your normal your normal finger prick will be normal most of the time.
Yeah, so that's the other levels. But the funny thing in medicine always is there's a normal, there's a pre-diabetes, and there's a diabetes. So how there's like one day I'm normal, next time pre-diabetes, and the next day I'm diabetic. So it doesn't work like that. It's all a continuum of things happening there. So the process starts slowly upping your insulin, trying to get more glucose through. Then the insulin stays high. You still manage to keep the glucose low, and then slowly the glucose starts to creep up to become a pre-diabetic and then a diabetic. It's a process over time. So we can change and turn that around with lifestyle. So we're going to move to the next one. Triglycerides.
So when you get stimulated with, let's say, glucose, but sucrose is pretty much a dimer between glucose and fructose. So we see fructose as much bigger problem than actual glucose. So glucose, the body loves glucose, and it functions on glucose. You have to have glucose. So if you don't have glucose, you'll die within minutes. So the problem is you stimulate this system with too much sugar, and especially fructose, and your insulin goes up, 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 and then the body pushes. It tries to handle all the sugar, and then your liver actually realizes, okay, but my glycogen stores are full, now liver and muscle. So evolutionary, we said, okay, but we won't eat every day. So we need to go store it somewhere, and that's how you make fat then. Okay, so the inside white fat that we talk about, the visceral fat, this is the triglycerides that we're talking about here.
And the thing is, we all are genetically different. So he can eat a certain amount of carbs, I can eat a certain amount of carbs, but we won't have the same response. Okay. So triglycerides give you a little window into your ability to burn carbs. So if your triglycerides are still low, you're probably doing quite well with the carbs. You use it for energy, you manage to burn it. If it starts to go up, then you're taking in more carbs than what your body actually are able to use.
Yeah, so in our tests, when we see someone that's really skinny and they've got body fat levels of under 15%, you see that level being really low. So where we see it is obviously the lipogram that we talked about earlier. So you've got a serum cholesterol, which then gets broken down, HDL, LDL, and triglycerides. So that's the triglycerides that we're talking about here. And you get the measure and you know exactly where you are. So if that's high, you got to think, okay, but if they haven't done my fasting insulin, that's the next place to go look, fasting insulin. And again, we don't treat diabetes as such. Where we are, lifestyle intervention is the fix here. Lifestyle intervention. It's less carbs, but actually more the other side, more exercise. Use that sugar.
I think we can move quickly to section 2. Here we have, should come up there, ferritin.
Yeah, so this is actually a personal story. So we got to this. There's a very nice podcast that we do with Professor Vernon Lowe on our podcast. It is amazing. So if you can listen to that, I've spotted a few people here. We've got an iron clinic that we run with this, and I've spotted a few people here that have got low irons. We're now so attuned to this, but this is so personal. My wife started mountain biking. And she told me, but I've just had 2 babies. I just cannot ride up a hill. I cycle as much as everyone else, but I just can't get there. Started looking, and we found a ferritin level to be 18, which is really low. I mean, we actually, our previous month's podcast is with an iron lady from Free State University about iron in athletes, which is a subject on its own. But especially the ladies, if you do not know your ferritin level by heart, at least every year, but we think every 6 months, then you're flying blind. And that is actually the thing that makes your energy. That waking up and feeling tired, but more importantly, the ladies will know when they were pregnant or early menarche, when they were youngsters, they feel that big dip just after lunchtime. They feel like they literally have to go for a nap to get through the day. And that is ferritin, energy. So men die with normally too much ferritin, just because the body can't get rid of it. So you need to test the ferritin. And if your ferritin levels are high, you need to have a full breakdown of iron. But this is amazingly important. So, and people say to me, but should we do genetic screening? So this new phase or fad that you do genetics and all, and where do my genetics? Am I someone that methylate too much? Or it doesn't matter. You need the building blocks. You need to make sure that this machine can work. There's a lot of things we're not touching on, but I want to drive home that you need to know your ferritin level.
And I just want to mention something. Ferritin it's not a direct measure of the iron, but it's actually the stores in your body of the iron. That's why we use ferritin as a screening test, and we'll take it further from there.
Yeah, make it easy. Say ferritin. It's a tin of iron. Ferrous, ferritin. Just think about it that way, and then you will remember. So,
and if you go look at the stats in the Western Cape, I mean, 57% of the women low on iron. We also, when we pick up something like that, we'll go look into reasons why it's low, obviously, the normal medical stuff, but just keep iron on your mind. It's a very important thing. And as Rudy mentioned, with men, it's often the other way around. Men often has too much iron.
And again, it's a screening test, ferritin, that if it's high, you do a full iron studies, you get your serum iron, transferrin saturation, and your ferritin. And if your transferrin saturation is under 45, forget about your high iron, then it's not a problem. But if it is higher, you need to know that you're not hemochromatotic, so that you have someone take that iron off you, because it will make problems. Again, like blood pressure, it's not now. It's planning for 10 to 15 years. That's what you're planning.
Okay, so the next one is vitamin D.
That's quite an interesting one, because vitamin D is a misnomer. It's actually a hormone, but we've been taught to put on SPF, but we need to make a lot of vitamin D. Okay, so body needs somewhere between 2.5 to 4,000 international units of vitamin D per day. So if you don't get in the sun, so to have enough vitamin D, you need to be with an exposed torso, 30 minutes in the mid-morning sun. No one does that. Okay, so if you don't know your vitamin D levels is actually normally low. So there's almost in all our screenings, we find people under 21. It is low.
Yeah, that was quite an interesting thing in this journey that we went through, is that we test vitamin D on everyone. And I think we had one normal vitamin D so far, which is crazy. You think sunny South Africa, we should be fine. No, everyone is low in vitamin D. So that's another number that you need to know.
And just to again say, that the COVID drove this home, because we realized we tested vitamin D, and we realized, but with vitamin D, it's got a massive piece in the puzzle of immunity. But it's been known to be the orchestrator of calcium and magnesium in bones. So that is actually where we hear most of it. But you cannot form testosterone properly if you don't have vitamin D. And ladies, you think we talk about testosterone only in men? Remember, you've got more testosterone in your body than you've got estrogen. So you need testosterone as well. Okay, so don't think when we talk testosterone, it's only men. And that is a part of what we do, but I think this talk, what we're driving towards is that the bottom of this pyramid is find your numbers, so you can actually build on this to have to number one, not have disease, and then to thrive. Why we're all here to thrive, you need to know these numbers to get them, especially vitamin D, ferritin, that type of values you need to know.
One point on the vitamin D as well, we've got deficient and then normal and optimal. Okay, so deficient is, in most lab reports, will be under 20. Okay, and often you'll get your vitamin D done, and the vitamin D might be 25, and the GP will say it's normal. It's not normal. Well, according to the lab, it's normal, but it's definitely not optimal. We aim for a level about 40 to 60. That's sort of the sweet spot, and we try and be in that sweet spot.
Yeah, and it's got quite a wide range. So your highest level is 100, and we've got people taking 5,000 international units daily, and they don't hit over 100. So there's quite a big scope to supplement with vitamin D. And if we leave here and you only take vitamin D as a pill, it's something you need to test, and you can supplement. It's actually quite cheap to supplement, but that is something that can change your life.
Yeah, and I just want to touch on that. It's just, don't go buy iron and vitamin D now without knowing your numbers. Okay, you need to know your number before you start these things, and you need to retest them to make sure that you're actually getting where you want to be with your numbers. I'm going to move along to this little number VO2 max.
How are we doing for time? Are we okay?
Yeah.
So again, if we do tests, we want to know what they tell us. So VO2 max is such a good proxy for how this whole system is running. case, because if you're fit and your VO2 max is like Taddy Pogacar's VO2 max of over 80, then it means you're really fit. But why do we test it? We want to make sure that if we're going to be a kick-ass 80-year-old, you have to have a VO2 max of above 30. But because this engine turns its best function at around 30, you will start losing about 10% of your VO2 max for every decade as you go along. So if you keep doing what you're doing at 30 and you just keep the same exercise, you will just trickle down and have 10% less every decade. That's how it works. It's just the numbers. So again, knowing your numbers now will tell you, okay, I must up what I do now, or if I do what I do now, I will have a VO2 max of 30. That means I can take the grandchildren walking around the block, carry my own groceries into the house, up some stairs, because that's what we're planning. I mean, we don't want to know where we are now unless you're an athlete, but we test the VO2 max in our clinic that we want to plan how you're going to be when you're 80.
Yes, and in our next talk, we'll go a little bit deeper into the VO2 max, but I think the main message here is if you go look at that top line, the top 2%, they've got an 80% less chance of dying compared to other people. That's massive. Okay, so fitness do matter. Another measurement in fitness as such, and we'll touch on that on the next talk as well, is grip strength. So, yeah, a strong handshake predicts a strong future, I would say.
And again, it's a proxy for what you can do. Can you pick up the groceries? Can you pick up the grandchild? That is what we're trying to do here. And if you are picking up heavier stuff every day, which we all should do, because I just want to come back. What are we trying to not have here? We're trying someone not lose their muscle and not lose their brain. Because that's at the end of the day what we're planning here. I mean, a heart attack and a stroke will make you not be able to move or not be able to exercise. You lose muscle, so sarcopenia. Huh? So and dementia or the neurodegenerative diseases, we don't want to lose our brains. So if we can keep our muscles and our brains for as long as we can, that is what we're testing here. So, and at the end of the day, I mean, you guys here are already 5 steps ahead of the general population because you are hungry for what you can do to make yourself thrive. So, and what we're trying to say is, but just get the numbers of where you are now that you can thrive even more.
Well, this is just some stats proving that. But yeah, at the end of the day, this is the message. Best time to know your numbers is now. Or was yesterday. The next best time is today. So, thank you.
Disclaimer. This podcast is not intended as a substitute for the advice of your healthcare provider. No doctor-patient relationship has been formed through this podcast. The content here is for information purposes only.